Kia ora everyone. Our presentation today is around the Mobility Action Program for Northland for 2018, and I'm going to present about some of the data that we've got so far and a few cases on each level as well that we've seen come through Northland. So this is a little bit of background just around the program. Most of those of you who are participating in the program are fully aware of this, but we're trying to socialise this a little bit beyond those who are using the program. So feel free to share the video link or for people to understand a bit more about MAPS. We know that our one is looking at lower back, shoulder, hip, knee OA, and we realised early in the process that the referral tools, because of the self-assessments that are required of the patients and the time it is to invite people in to participate in the program, we had to allocate some funding to fund the nurses to do those referral forms. And then our levels of funding are matched to the complexity of the patient, tahi rua or toru, with more services at each level. We know that osteoarthritis is increasing internationally in terms of the global burden of disease. So we know that back in the 90s it was number 18, and the latest rankings in 2015 show that it's sitting at number 13 at the moment. And we know from Northland's perspective, what's helped us a lot is having this as an e-referral in our existing patient care management service, which is how we refer for mental health packages of care, the same way we can refer for MAPS packages of care. And you can see kind of how many packages you've got left allocated to your service, because we've got a maximum of 400 packages of care within Northland. We will be running out this year of packages, and then the Ministry of Health funding is finite funding, and we'll need to find ongoing sources of funding if we're going to continue this program. We did safeguard this a little bit. If you look at the right bottom hand of the screen, is that there is the option for patients to self-fund a package. So obviously for a tahi package that only costs $300, and as one of my colleagues said, you know, it's a pair of shoes these days. So some people will be willing to have 5 sessions of physiotherapy at a rate of $300 to help them manage their pain better and increase their mobility. And then the other forms of, that's just the screens that you'll see with the MAP enrollment. And because it was a pilot, we had to do these scoring tools. You've experienced the pain tool, which I've got here, and the self-management Stanford self-efficacy score. There's also the health and well-being score, which is that SF12 version 2 score, and that's also in the electronic form. So you just need to scroll right down to the bottom of the form and make sure all the self-assessments from a patient perspective have been completed. We know that we've had challenges with some patients' health literacy and understanding of the questions, and it's just important for us as providers to not direct the patient, but to perhaps explain it in a different way for them so that they're aware of what they're scoring themselves. And the other thing is that this has been really helpful for us. So you'll see in the case presentations that we can really see some changes in outcomes for patients from the beginning of the program to the end of their program. And then the loop is closed at the end of the program, where we get our discharge notification back into the inbox of our patient management system. And if you look into the form, you will see that the patient has either completed the program, they may have been lost to contact, so they haven't completed the program. They also will be indicated whether they're managing their condition better or the condition has only been partially resolved, because we had a few cases where this was occurring where they would need some ongoing follow-up with general practice. So if the presenting issue partially resolved is ticked, it's probably best as a general practice team to touch base with that patient and just see how they're going. So what I'm presenting today is kind of up to this month. We looked at how many patients we had on the program, and this is patients both completed or who are currently undergoing participation in the program. And we've got 336 across our pilot sites in Northland. And so these next slides will be talking about those numbers. So our breakdown of numbers in Northland is that mostly we're seeing 69% of females being referred and only 31% males. So there is a bit of, we know that osteoarthritis does affect females slightly more than men. However, we're probably seeing a little bit of underrepresentation of males, perhaps because they're not presenting to general practice in the first place with their musculoskeletal condition. And then if we look at age distribution, you'll see that most of our patients are over 55 and in that older age group, which we would expect. But there is a good proportion still in that under 55-year-old age group. And it's important, we did a presentation last year on premature osteoarthritis, and I'll go into that a little bit in the following slides. So the ethnicity breakdown for our program for MAPS is really equitable to our population demographics. So in Northland we have about 34% Māori, and we're getting that uptake within this program. So our New Zealand European patients are still the majority of referrals through this program, but we've got a good number of Māori and other ethnicities being referred as well. But if we look at our data a little bit more closely, if we look at that under 55-year-old age group, we're really overrepresented from our Māori patients, and we need to think about that a little bit in regards to higher rates of obesity in our younger age groups, and also there are genetic factors which I'll go into. So we found out more recently in terms of studies that leading cause of premature osteoarthritis in younger people is related to this interleukin 1 gene cluster, and we know that that's actually also associated with early onset of diabetes and cardiovascular disease. And we know that on a wider perspective that Māori are nationally affected more by diabetes and cardiovascular disease at a younger age level. So we need to be thinking about this going forward, and whether there's any research occurring at the moment around this. So if we look at comparing our MAPS data with our first specialist appointment data and e-referral data for orthopaedics in Northland, actually we underrepresent our Māori population in the secondary services. So we're really less than a quarter of our referrals are for Māori into the secondary services. So it's really important to be mindful that, I think in a reflection, hospitals were established and developed for a European society, and probably if we look back in terms of Māori culture and traditional Māori thinking, is that actually if we look at the use of tohunga and other things, Māori were probably a very much primary care based health situation pre-European, and so we need to be thinking about what actually does work for Māori and how we engage with Māori and how Māori are represented in programs like this. If we look at the breakdown of service allocation for Northland in our MAPS program, most people are only engaged with a single provider, and that will mainly be our physiotherapists that are out in the community. The next proportion is obviously with 2 providers, and that may be whakamana in hauora and physiotherapy, or it might be podiatry and physiotherapy, or it may be occupational therapy and physiotherapy. But then your smaller section, which is at the top there, they're accessing 3 or 4 services, and that's our toru group So our tahi is a single service, rua is a couple of services, and toru is, and that's what we expected. We expected that would be the breakdown of numbers in terms of those that are most complex will need toru involvement and multiple provider input into them, but most are settled with just single provider input. So the complexity of our program is that I just wanted to acknowledge we've had a couple of younger Māori patients that have died while on the program, and that's really been secondary to their comorbidities, not due to the program. And we have to be mindful that it is around these other comorbidities of cardiovascular disease, diabetes, morbid obesity that lead to premature death in this population. One of the feedback from one of the partners of our, participants was that there were definitely some challenges along the way in terms of the program, but also benefits not just to that person but to the wider whānau. And that was around kind of this particular spouse has kind of had linked into an ongoing relationship and working with Arthritis New Zealand in the north. So there's some, we have to be mindful that with programs like this there are often unseen or wider things that are not just about the person who's been referred themselves. Looking at outcomes of the packages, so most of ours complete and managing their condition better, and there is a small percentage, about 14 cases, that their condition was only partly resolved by the program itself, and then another small amount that did still require referral onto secondary services. So we need to have a look a little bit more about that. Were they appropriate referrals in the first place, and did they still actually gain benefit? We have one particular case of a PHO staff member's family member that came onto the program, participated in the strengthening, had a couple of joint injections in primary care, and still things weren't resolving and still things continued to deteriorate, so has gone on to have a joint replacement. But in reflection of both the person and her whānau was that if she hadn't done the strengthening program prior to her surgery, then actually her recovery may have been a much longer process and more issues with increased to normal mobility, which she's back to already. So the case presentations, they're fairly, I've written them quite comprehensively because I didn't want people to be able to lose the essence of what goes on behind a referral and also what happens to the person once you've sent that referral off. So this is our tahi level example, and it's all of my cases are Māori across Northland, because I think, again, if we're demonstrating equity, some of the social complexities that contribute to why Māori find it difficult to engage in mainstream services are reflected in some of these cases as well too. So this person had just arthritis of her left knee. She had couple of low-key comorbidities and was working part-time, but did have limitations around her functional mobility and her ability to participate in work, but wasn't having any kind of psychological effect or it impacting on her general social interactions. So she'd already had an appointment with an orthopaedic surgeon in the referral that came to us from primary care, who had recommended that this woman have arthroscopy. But from our perspective, she was really quite simple and straightforward, and so we just referred her for a tahi package of care for 5 physiotherapy and asked her if she would want to participate in the mana order. Now, just a bit of a brief thing. This was a slide presented at one of our CMEs last year. Actually, international guidelines say we shouldn't be doing arthroscopy for knee osteoarthritis unless there is some clear mechanical locking occurring in the joint. And that was published in 2015 in the BMJ, so it's recent evidence-based updates. Our outcomes for this patient, as you can see, are quite beneficial. She's had improvement across her pain scores and her functional up and go score. And basically, down in the bottom left corner, what we're trying to demonstrate with our cases is that this is a timely program from referral to first appointment. So we know that there are long waiting lists within the DHB, we know that there are long waiting lists from a hospital perspective for physiotherapy. MAPS produces access to physiotherapy within a timely way, on average within a month of referral to commencement of first appointment. So as you can see, this patient, beyond her objective scoring, subjectively is now able to work with no pain and is not taking any ongoing medication. So there's cost savings in regards to pharmaceutical budgets, but also cost improvements from a workforce perspective. Our second case is in the Rua category, and this is a 65-year-old Māori male. He had osteoarthritis of his spine, lower back, and was unemployed secondary to his musculoskeletal condition, and definitely was having an impact on his life in terms of social engagement, in terms of how he was feeling, depression symptoms in regards to his pain and things like that. So initially, when it was triaged from a PHO perspective, the nurse wondered whether this should sit in tahi, but after consultation within our MTT process, it was decided to give him a Rua package, and that we thought he would likely need some support around transport because of how far away from his clinic that he lived. And the background thing is that actually these services take a little bit of extra things beyond just a referral and allocation of package service. It's around the coordination role that we can see, we know have benefits from a primary care perspective in our primary options program. Well, similarly here, MAPS has benefit from having a coordinator role that's based within the PHO. And that's a go-to person for patients when they have issues or challenges in accessing their program. So this patient, there were numerous ways of trying to make contact with this patient. His phone number changed during the between the referral and the commencement of his program. We're seeing that a lot as well too in terms of keeping in contact with patients, that cell phones are changed faster than tyres sometimes, I think, on cars. And anyway, so ultimately he was again a timely referral to commencement of his program at the end of last year, and he's had lots of benefit from this program. As you'll see, he's really able to get to a full range of movement. He was pain-free, able to do more self-management at home. And so if you look at his pain scores and his functional scores from beginning to end of program, again, immediate benefit to him as a person. The patient-centred case for the toru level, again, our more complex patients. This is a woman with hip osteoarthritis who unfortunately is on dialysis 3 times a week and lives very rurally, north of Whangarei. And her pain score was quite high as well, and it was affecting a lot in terms of her social interaction and health and well-being. This took a lot of coordination from a perspective. We had to work with the renal team, the social worker there, trying to get, because this patient had no transport, it was around trying to get things in place so that the dialysis van could do a slightly earlier pickup. We could fund her transport from being dropped off at the front door of the hospital to the physiotherapist and then back again. We were able to work with our OT providers out in the community to be able to support this person to have her OT input between the time from her physio appointment to the time of her dialysis. Again, saving extra trips and travel down into town. She's ongoing having her still in the program as well too. She's still, as a a toru patient, they can be engaged for quite some time on the program, so it's really around making sure that things are progressing, and so there's extra capability to re-refer into other providers within the toru program. So it may be that the providers feel that something extra comes up, that maybe they may need psychosocial support or other inputs from other providers in terms of dietitian support and things. So the coordinator can allocate based on the total package of care what's specific to that patient. And I think that's the joy of our program, is that it is very patient-centred and can be flexible in the sense that it doesn't need to be a one-size-fits-all process. And so these are just some of the things that we looked at last year from an update perspective within the program for our providers, and just a reminder about the tools that we've developed locally. And if you don't have them within your practice, I would encourage you to contact Audrey, the coordinator, to get these, because I've definitely started using them for my non-MAPS patients as well too. So your tūmeki was adapted from the sport Waikato to a Northland perspective, basically, looking at the options and choices for patients. So one pager that has a double-sided, and this page is around patients doing a self-assessment, seeing where they're at in terms of lifestyle and healthy eating choices, and figuring out what's their priority, their first goal. Last year I did the Healthy Conversations training up here in Northland, and that's another good training, really around putting it back to the patient around things that we know that actually when we bombard them and overload them,